Okay, let's dive in. You've brought us some fantastic source material today, really digging into symptoms that are, well, incredibly common, yet surprisingly complex to pin down: dizziness, vertigo, and fatigue.
They really are. Almost everyone experiences these feelings at some point, right? But the source material highlights something crucial right away. Patients often find it really difficult to articulate exactly what they're feeling.
And that imprecision, that's the first big hurdle, isn't it, in figuring out what's actually going on?
Exactly. That's the challenge laid out in this detailed clinical material you've shared. This isn't just skimming the surface. It really pushes us to go deep, understand the nuances, and, master the diagnostic approach like true professionals.
And that's our mission today with this deep dive. We're going to extract every important nugget from these pages, clarify those subtle but critical distinctions, explore the surprisingly vast landscape of potential causes, and lay out the diagnostic and treatment strategies discussed.
Right. This isn't about a quick overview. It's about building a thorough, really expert-level understanding.
So if you're here to cut through the confusion and truly get a handle on this material, you are absolutely in the right place. Let's unpack this.
The source starts by zeroing in on the very language we use. It makes a crucial point. Dizziness isn't a single specific symptom. It's an umbrella term.
A catch-all word patients use for several very different sensations.
And that imprecision is why simply asking, "Are you dizzy?" just isn't enough. You
Yeah.
have to dig deeper because, well, patients mix these terms up constantly. The text gives us clear definitions, which is super helpful.
Okay, let's break those down. First up.
First, there's vertigo. This is the illusion of motion, is the feeling that you are spinning or maybe the environment around you is spinning or moving.
Right, the classic spinning sensation.
Yeah. And the source notes it can be physiological, like, after you spin around really fast and stop, or it can be pathological, which means it comes from a problem in your balance system, the vestibular system.
Got it. Okay, what's next?
Then you have lightheadedness. Now, classically, the source describes this as the pre-syncopal sensation, that sort of woozy, faint feeling that comes from your brain, maybe not getting quite enough blood flow.
Like you might pass out.
Exactly. But, and this is a key insight from the source, patients also use this word to describe unsteadiness or imbalance, which isn't the same thing at all.
So even lightheadedness can be ambiguous when a patient says it.
Totally lacks specificity sometimes, which leads us right into faintness, potentially leading to syncope, which is actually losing consciousness.
Okay.
The source material really emphasizes if someone describes dizziness as brief episodes, or if it happens particularly when they stand up,
You should be thinking about fainting.
you should always be considering faintness or potential syncope.
Yeah.
The source mentions another section goes into syncope in more depth, but that feeling of about to pass out is often labeled dizziness by patients. Very relevant
It
here.
makes sense. And the last one?
Finally, there's imbalance or disequilibrium. This one's maybe more straightforward. It's simply the feeling of unsteadiness, of not being stable on your feet, like you might fall over.
Okay, so vertigo, spinning, lightheadedness, pre-faint but used loosely, faintness, syncope, passing out, and imbalance, unsteady.
Exactly. And the first major takeaway, hammered home by the source, is that fundamental diagnostic challenge. Because patients often can't precisely distinguish or describe which specific sensation they're having, their initial complaint of dizziness is often not reliable enough on its own.
You absolutely have to ask those follow-up questions to clarify the type of sensation.
They really do.
Okay, so with those critical definitions in hand, let's talk about where these sensations actually come from. This source material breaks down the causes into logical categories, which seems essential for a systematic approach.
Absolutely. The largest category, maybe not surprisingly, is vestibular dizziness. This covers both vertigo and imbalance that result from issues anywhere within that vestibular system.
And that system has parts inside the ear and parts in the brain, right?
Exactly. You've got the peripheral components, the labyrinths, those balance organs deep in your inner ear, and the vestibular nerves carrying signals to the brain.
Okay.
And then you have the central components problems located in the brainstem, the cerebellum, or the pathways within the brain that process all that vestibular information.
And the source material gives some insight into how problems in these areas cause symptoms.
It does, and it's a crucial distinction. If you have an acute unilateral lesion, meaning a sudden problem on just one side of the vestibular system, that's what typically causes intense vertigo.
Why the asymmetry?
Think about it. You suddenly have this massive mismatch in the balance signals going to your brain. One side sends a normal signal, the other side sends a faulty one, or maybe none at all. Your brain gets totally conflicting messages and interprets it as spinning.
Right. It's like one side is yelling, "We're moving," and the other is silent, total confusion.
Precisely. But interestingly, if you have bilateral lesions where function is lost on both sides, either simultaneously or progressively.
You usually don't get vertigo.
Correct. Because there's no longer that asymmetry in the signal. Instead, what you typically get is imbalance and something called oscillopsia.
Oscillopsia, what's that?
That's the feeling that the world is bouncing or blurring whenever you move your head. It happens because you've lost the normal reflexes, the vestibulo-ocular reflex, or VOR, that usually keep your vision stable during head movements.
Ah, okay. So asymmetry causes vertigo, bilateral loss causes imbalance, and oscillopsia. That's a key concept.
Definitely a key concept for mastering this. Then there's the category of presyncopal dizziness we touched on, directly caused by that transient cerebral hypoperfusion, not enough blood flow getting to the brain temporarily.
And the source gave examples.
Yeah, things like cardiac dysrhythmias, heart rhythm problems, orthostatic hypotension that drop in blood pressure when you stand up, or even side effects from certain medications.
And these feelings can either get worse until you actually pass out, or they can just resolve.
Exactly. They can ramp up and lead to syncope, or they can resolve if blood flow gets restored quickly enough.
Okay. Are there other major categories of causes?
Yes, the text points out that dizziness can stem from other causes besides strictly vestibular or presyncopal issues.
Like what?
This includes non-vestibular imbalance or gait disorders. The source gives examples like sensory neuropathy, where you lose proprioception, your body's sense of where its limbs are in space, or conditions like Parkinsonism, which directly affect your gait and stability.
So, problems with walking or sensing your body position, not necessarily the inner ear itself.
Right. These can make you unsteady without a primary issue in your inner ear or the brain's balance centers. And very importantly, the source also lists anxiety as a significant contributor to dizziness, particularly the chronic or functional types.
Okay, that's a lot of potential causes. So, faced with a patient complaining of dizziness, how does one systematically work through this maze?
Well, the source provides a really clear, focused approach. It's guided by 3 fundamental questions. These questions are basically the core structure for the diagnostic process.
What are they?
You have to ask, 1, is this potentially dangerous? Meaning, could this be something serious like a stroke or a heart problem? 2, is this dizziness actually related to the vestibular system? And 3, if it is vestibular, is the problem peripheral out in the ear or nerve, or is it central, originating in the brain?
Dangerous, vestibular, peripheral, or central.
Those are the big 3. And a really powerful insight from the source is the emphasis that a careful history and a thorough physical examination are often sufficient to answer these crucial questions and figure out what to do next.
You don't necessarily need a battery of expensive tests right away.
Not always. A good clinician can often get most of the way there just by listening carefully and examining the patient properly.
So let's talk about that history. We already established that just asking what does it feel like can be unreliable because patients use the words loosely.
Exactly. The ambiguity of the terms they use means you have to go deeper.
So what specific details does the source say to focus on?
You want to know, is this the very first time this has happened? What's the duration of the episodes? Are we talking seconds, minutes, hours, or days? What provokes the dizziness? Are there specific movements, positions, situations? And crucially, what accompanying symptoms are present?
Okay, let's unpack those. Duration seems like a big one.
Incredibly valuable. The source links specific durations to common culprits. For example, episodes lasting just seconds, especially if triggered by position changes.
Like rolling over in bed or looking up.
Exactly. That strongly suggests things like BPPV, benign paroxysmal positional vertigo, or maybe orthostatic hypotension.
And if it lasts longer, say minutes.
Attacks lasting several minutes raise suspicion for things like TIAs, transient ischemic attacks, those mini strokes especially affecting the back part of the brain, the posterior circulation. Though vestibular migraine and other causes are also possible in that time frame.
And longer still, hours.
Episodes lasting hours are more characteristic of conditions like vestibular migraine or Ménière's disease.
So timing is a huge clue. What about those accompanying symptoms? How do they help sort things out?
They're one of the most effective ways to differentiate between peripheral and central causes, which gets back to that third key diagnostic question.
Okay, give me some examples. What points towards peripheral?
If the dizziness comes with unilateral hearing loss just in one ear or other, acute symptoms limited to one ear, like ear pain, pressure, fullness, or a new ringing sound, tinnitus, that strongly points towards a peripheral problem.
And why is unilateral hearing loss such a strong peripheral sign?
The source explains it well. The auditory pathways, once they leave the ear and enter the brainstem, become bilateral very quickly. They cross over. So a central lesion, unless it was in a very specific spot right where the nerve enters, is highly unlikely to cause hearing loss limited to just one ear.
Makes sense. So what symptoms scream central cause?
If the dizziness is accompanied by classic neurological symptoms, things like double vision, diplopia, numbness, weakness in a limb, difficulty speaking clearly, dysarthria, or limb ataxia, that's like clumsiness or incoordination of an arm or leg, those are major red flags.
Suggesting the problem isn't just the inner ear, but likely the brainstem or cerebellum.
Exactly. Those symptoms point towards a central lesion.
Which logically brings us to the physical examination. According to the source, a focused neurologic exam is absolutely critical here.
Critical. You're looking closely at specific things. The range and equality of eye movements, for instance. Are they moving together smoothly? You're checking for disconjugate eye movements.
Meaning the eyes aren't moving together properly.
Right, maybe one eye lags or they aren't aligned. That can suggest a peripheral issue affecting the cranial nerves controlling the eye muscles, or the muscles themselves.
What else are you assessing in the eyes?
You also assess pursuit, the ability to smoothly track a moving target, like your finger and saccades, which are the quick, jumping eye movements used to shift gaze from one point to another.
And what do problems there tell you?
The source notes that poor, jerky pursuit or inaccurate saccades that overshoot or undershoot the target, called dysmetric saccades, usually indicate a central pathology. Often it involves the cerebellum, which is heavily involved in coordinating those fine eye movements.
Okay. Any other eye tests mentioned?
Yes, the cover test is mentioned. This checks for eye alignment, looking for misalignment, especially a vertical one, which can be another clue pointing towards a lesion in the brainstem or cerebellum.
And then there's nystagmus. We hear that word a lot with dizziness.
Right, spontaneous nystagmus, those involuntary, rhythmic, back-and-forth eye movements. The source highlights how important it is to observe its characteristics carefully. There's even a table mention that gives crucial distinctions between peripheral and central types.
Ah, like a cheat sheet for telling them apart based on how the eyes are moving?
Pretty much. That table is gold. For instance, peripheral nystagmus from an acute issue is typically unidirectional, meaning the fast phase of the eye jerk is always in the same direction, usually beating away from the side with the lesion, and it's often horizontal or maybe horizontal with a slight twist, horizontal torsional.
And central nystagmus is different.
Often, yes. Central nystagmus frequently changes direction with gaze. It might beat to the left when the patient looks left, and then beat to the right when they look right. That's called gaze-evoked nystagmus, and it's usually a central sign.
Interesting. What other key distinctions does that table make?
Another critical one. The nystagmus in BPPV is transient. It comes on after a delay and has a specific mixed, upbeating torsional pattern. But if you see pure vertical nystagmus, the fast phase is straight up or straight down, or pure torsional nystagmus, where the eyes just rotate like wheels.
That's bad.
The source states that is a central sign. The parts of the brainstem and cerebellum controlling purely vertical or purely torsional movements aren't directly linked to the semicircular canals in the way horizontal movements are.
Okay, pure vertical or pure torsional, think central. What about fixation? Does looking at something change it?
Yes, that's another key point. Peripheral nystagmus is typically suppressed by visual fixation. If the patient focuses their gaze on a target, the nystagmus often decreases or stops completely.
But central nystagmus doesn't care if you're focusing.
Usually not.
Yeah.
It's typically not suppressed by fixation. That's why clinicians often use special goggles, like Frenzel goggles or infrared video goggles. They block the patient's ability to fixate visually, making it much easier to see underlying peripheral nystagmus.
Clever. Any other nystagmus clues?
The text also points out that if nystagmus is easily visible when the patient is just looking straight ahead in the primary position, in normal room light, it's more likely to be central. The exceptions is during a very acute, severe peripheral vestibulopathy, where it can be quite prominent initially.
And specific central types were flagged.
Yeah, things like downbeat nystagmus, where the fast phase is downward, and that gaze-evoked nystagmus we mentioned, changing direction with gaze.
Okay, so observing eye movements is huge. But there are also specific bedside tests you can do.
Absolutely. Powerful tests to directly assess vestibular function. The head impulse test is highlighted as one of the most valuable.
How does that work?
It tests the vestibulo-ocular reflex, the VOR. The clinician holds the patient's head and asks them to keep their eyes fixed on the clinician's nose. Then the clinician makes quick, small, unpredictable turns of the patient's head to one side or the other.
And what are you looking for?
If the VOR is working correctly on the side the head is turned towards, the eyes should stay locked on the nose, perfectly stable. But if the VOR is deficient on that side, the eyes will get dragged along with the head for a split second. Then, after the head movement stops, you'll see the eyes make a quick corrective jump, a catch-up saccade, back to the target, the nose.
So that catch-up saccade tells you the VOR on that side isn't working right.
Exactly. If you turn the head left and see a catch-up saccade, it means the left vestibular system is weak. If you see saccades when turning the head both ways, that suggests bilateral hypofunction, problems on both sides.
And this test has particular importance in acute vertigo.
Critically important. Here's the key point the source emphasizes. If a patient presents with acute, continuous, severe vertigo, but their head impulse test is completely normal,
No catch-up saccades.
no catch-up saccades at all, that is a major red flag. It strongly suggests a central cause, like a stroke in the cerebellum. The VOR pathway itself is intact, meaning the inner ear and nerve are likely working fine, so the problem must be higher up in the brain.
Wow, okay. That's a crucial diagnostic point. What other bedside tests are key?
The Dix-Hall-Pike maneuver. This is the gold standard test for diagnosing that common positional dizziness, BPPV.
How's that one done?
The source describes it clearly. The patient starts sitting up on the exam table. You turn their head 45 degrees to one side. Then, supporting their head and neck, you quickly lower them backwards so they're lying flat, supine, with their head extended slightly off the end of the table, still turn 45 degrees to that side.
And then you watch their eyes.
Intensely. For at least 15-20 seconds, or until any symptoms stop. For the most common type, posterior canal BPPV, you're looking for that characteristic nystagmus to appear after a brief delay, maybe a few seconds. It's typically transient, lasting maybe 15-30 seconds, and it's usually upbeating and torsional twisting. The patient will usually report their typical vertigo at the same time.
And you do it for both sides?
Yes, you bring them back up, let them recover for a moment, and then repeat the whole maneuver with their head turned 45 degrees to the other side. And again, using those Frenzel goggles can make subtle nystagmus much easier to spot.
Okay, Dix-Hall-Pike for BPPV. Any others mentioned?
Finally, the source mentions dynamic visual acuity as a functional test. This is where you measure how well the patient can read a standard eye chart with their head held perfectly still.
Baseline vision.
Right. And then you measure again while their head is being gently moved side to side by the examiner, maybe at about 2 hertz, like shaking your head no twice per second.
And what constitutes an abnormal result?
If the patient's visual acuity drops significantly, the source says more than one line on the eye chart when their head is moving compared to when it's still, that's abnormal. It indicates their VOR isn't effectively stabilizing their gaze during head movements, which points towards vestibular dysfunction.
So another way to assess that VOR function, okay, we've gone deep on the history in the physical exam. When do you need more? When do you order tests?
Ancillary testing, according to the source, really should be guided by what you found or suspect from that careful history and examination. It's not meant to be a shotgun approach.
You're ordering tests to confirm or investigate specific suspicions.
Precisely. For example, audiometry formal hearing test is crucial if there's any hint of hearing symptoms. We already talked about how unilateral sensorineural hearing loss points towards peripheral causes like a schwannoma. And the source specifically notes that low-frequency hearing loss is a characteristic finding in Ménière's disease.
So hearing tests are often needed. What about more specialized vestibular testing?
Yes, there are more detailed tests available. Videonystagmography, or VNG, records eye movements during various tasks and can assess the function of the semicircular canals and nerves more formally. Caloric testing is usually part of a VNG. It involves stimulating each ear canal with warm and cool water or air to compare the responses of the horizontal canals. It's a classic test of peripheral function.
Sounds unpleasant.
It can be for some patients, yeah. More recently, there's video head impulse testing, or VHIT. This uses high-speed cameras to objectively measure the VOR gain for all 6 semicircular canals, providing a more comprehensive and often better tolerated assessment than calorics.
What else is in the testing toolkit?
The source mentions vestibular evoked potentials, or VEMPs. These are tests that assess the reflexes originating from the otitive organs, the utricle and saccule, which sense linear acceleration like gravity and forward-backward motion.
So testing different parts of the balance system?
Exactly. And you can also do more detailed recordings of saccades and pursuit eye movements, which gives more quantitative information about central ocular and motor control pathways if you suspect a central issue.
And finally, imaging.
Right, neuroimaging, primarily brain MRI. This is essential if your history or exam findings raise suspicion for a central disorder, things like stroke, a tumor, multiple sclerosis.
When else is MRI needed?
The source makes a very specific point here. If you find unexplained unilateral sensorineural hearing loss or objective evidence of unilateral vestibular hypofunction on testing, like from VNG or VHIT, you need an MRI of the internal auditory canals with gadolinium contrast.
Why that specific MRI?
To definitively rule out a vestibular schwannoma, that tumor on the nerve, even if the patient doesn't have any other obvious central neurological signs, it's the gold standard for detecting those.
Okay, that makes sense. So using this whole diagnostic framework, history, exam, targeted testing allows you to arrive at specific diagnoses. And the source emphasizes that treatment must be guided by the specific diagnosis, right?
Absolutely. And a key principle highlighted right away is about medications, those vestibular suppressants like meclizine or diazepam. The source stresses they are often not helpful beyond the very acute phase, maybe the first few days, and can actually hinder the brain's natural recovery and compensation process. There are exceptions, but it's a crucial point.
Okay, let's walk through some of the specific conditions mentioned and their management, starting with that acute prolonged vertigo.
Right, acute prolonged vertigo, often caused by vestibular neuritis. This is usually thought to be due to inflammation, probably viral, affecting the vestibular nerve on one side. The symptoms are pretty dramatic. Constant, severe vertigo, often with intense nausea, vomiting, and that oscillopsia, the bouncing vision.
And it feels like continuous spinning, doesn't stop when you hold still.
Exactly. Unlike BPPV, it persists even when the head is stationary. Now, the absolute highest priority when someone presents like this is ruling out a central cause, particularly a stroke in the brainstem or cerebellum, because that's a true medical emergency.
So you're rigorously looking for those central warning signs we talked about.
Absolutely. Double vision, limb weakness, incoordination, numbness, difficulty speaking. And remember that head impulse test if it's normal in the face of acute, severe, continuous vertigo.
Think central.
Think central. The source even mentions that if the patient has significant stroke risk factors, imaging like an MRI might be prudent, even if they don't have obvious classic central signs, just to be safe.
How do people typically recover from vestibular neuritis?
Recovery is often spontaneous over weeks to months as the brain compensates, but persistent dizziness can sometimes occur. The role of steroids, like prednisone, is somewhat controversial but often used early on. Antivirals generally aren't helpful unless it's clearly Ramsay-Hunt syndrome, which involves the facial nerve too.
And those suppressants?
Only for the first day or two, maybe, to manage severe nausea and vomiting. After that, they can impede recovery. The real key for long-term recovery is vestibular rehabilitation therapy.
Okay, let's move to the most common cause of recurrent vertigo, benign paroxysmal positional vertigo, or BPPV.
Ah, yes, BPPV. This is characterized by those very brief, recurrent episodes of intense vertigo, usually lasting less than a minute, and crucially, they're always triggered by specific changes in head position relative to gravity.
Like lying down, sitting up, looking up high, rolling over in bed.
Exactly those movements.
Yeah.
And the spinning sensation is often quite intense but short-lived, and it tends to fatigue or lessen if you repeat the provoking head movement several times in a row.
And the source explains the mechanism, what's actually happening in the ear.
It does, and it's really quite elegant mechanically. Tiny calcium carbonate crystals, called otoconia, which are normally embedded in a gelatinous layer in a part of the inner ear called the utricle.
They get dislodged.
They become dislodged, maybe due to age, head trauma, or sometimes for no clear reason. Then these little rocks float into one of the semicircular canals, usually the posterior canal, because of its position.
And then what happens?
When you move your head into a specific position, like lying back during the Dix-Hallpike test, gravity pulls these loose crystals downwards within the canal. This causes the fluid inside the canal, the endolymph, to move abnormally, which inappropriately stimulates the nerve endings in that canal, sending a false signal to the brain that you're spinning rapidly.
Ah, so it's a mechanical problem. The crystals moving where they shouldn't be. That explains why it's brief and position-provoked.
Precisely. And the treatment, which is one of the real success stories in managing dizziness, is equally mechanical and highly effective. Physical repositioning maneuvers.
Like the Epley maneuver.
Exactly. The source describes the Epley maneuver in detail. The whole goal is to use a specific sequence of head positions to guide those loose crystals, using gravity, out of the semicircular canal and back into the utricle, where they belong and won't cause trouble.
Can you walk us through the steps for the Epley, as described in the source, for, say, right posterior canal BPPV?
Sure. You start with the patient sitting upright on the table. You turn their head 45 degrees towards the affected side, the right side in this case, which you identified with the Dix-Hall pike. Then, you quickly lay the patient back so they're supine, head still turned right, and slightly extended off the end of the table.
Okay, hold that position.
Yes, hold it for at least 30 seconds, or 30 seconds after any vertigo or nystagmus stops. Then, without lifting their head, you smoothly turn their head 90 degrees, so it's now facing 45 degrees towards the opposite shoulder, the left shoulder. Hold again for 30 seconds.
What's next?
Next, you have the patient roll onto their left side, kind of tucking their chin towards their left shoulder as they go, while you help maintain that head position relative to their body. So now they're lying on their left side looking down towards the floor at about a 45-degree angle. Hold that for 30 seconds.
And the final step.
Finally, slowly help the patient sit back up, keeping their head somewhat turned towards the left initially, then straightening it once they're fully upright.
And that sequence is designed to just shepherd the crystals out.
Exactly. It uses gravity to move them along the canal and dump them back into the utricle. The source mentions it's often repeated once or twice in a session, and there are home versions patients can be taught, plus specific maneuvers for the less common horizontal or superior canal variants of BPPV.
Fascinating. Okay, what about vestibular migraine? The source says this is common but often missed.
Very common, and yes, frequently underdiagnosed. It causes episodic dizziness or vertigo, and the episodes can range quite a bit in duration from minutes to hours, sometimes even days. And sometimes patients just have a more persistent sense of disequilibrium or motion sensitivity for days or weeks around an attack.
And the key thing is it doesn't always happen with a headache.
That's crucial. The vertigo can occur before, during, after, or completely independently of a typical migraine headache. Many patients with vestibular migraine never have severe headaches, or only mild ones.
So what else points towards vestibular migraine if there's no headache?
The source notes that patients often have other associated migraine features during their dizzy spells. Things like heightened sensitivity to motion, visual sensitivity, like finding busy patterns or fluorescent lights, really bothersome photophobia, light sensitivity, phonophobia, sound sensitivity, or sometimes even a visual aura.
And treatment.
Treatment generally follows the same principles as treating headache migraines. This often involves migraine prophylaxis medications, drugs taken daily to reduce the frequency and severity of attacks. And for acute attacks, antiemetics for nausea or sometimes specific migraine abortive medications like triptans might be used.
Right. Let's move on to Ménière's disease. What are the hallmarks there?
Ménière's disease is classically defined by episodic attacks that combine vertigo, fluctuating hearing loss, usually low frequency initially, and specific oral symptoms in the affected ear. Things like roaring tinnitus, a sense of ear fullness or pressure, or sometimes ear pain.
So the combination of vertigo, A&D hearing symptoms, and those ear fullness pressure feelings is key.
Exactly. Those are the key distinguishing features. Documenting that fluctuating, typically low-frequency sensorineural hearing loss on audiometry, especially if it gets worse during an attack and improves afterward, is very characteristic.
And what causes Ménière's?
It's associated with something called endolymphatic hydrops, which is basically an excess of fluid, endolymph, within the inner ear structures. However, the source notes the exact pathophysiology, why this fluid buildup happens and how it causes the attacks isn't fully understood.
Who typically manages this, and what are the treatments?
Referral to an otolaryngologist, ENT specialist, is usually necessary. Treatments mentioned in the source include dietary changes like sodium restriction and possibly diuretics, water pills, to try and reduce fluid volume. If those aren't enough, options include middle ear injections of glucocorticoids, steroids, or sometimes gentamicin, an antibiotic that's selectively toxic to vestibular cells, to reduce vertigo spells. Occasionally, non-ablative surgery like endolymphatic sac decompression is done, and very rarely ablative procedures that intentionally destroy inner ear function might be considered for intractable vertigo.
Okay. Now, what about vestibular schwannoma, also known as acoustic neuroma?
Right. This is a benign tumor that grows slowly on the vestibular nerve, usually where it exits the brainstem in an area called the cerebellopontine angle. Because it arises from the nerve sheath, Schwann cells, it's called a schwannoma.
And what are the typical symptoms? Is it vertigo?
Interestingly, no. A critical point from the source is why patients with schwannomas typically don't experience significant vertigo, because the tumor grows so slowly, often over years.
The brain has time to adapt.
Exactly. The brain gradually compensates for the slowly declining vestibular function from the affected ear. So the most common presenting symptoms are usually slowly progressive unilateral sensorineural hearing loss and often tinnitus on that side. Sometimes mild imbalance develops later.
So diagnosis can be delayed if the hearing loss isn't noticed.
Often, yes. On examination, you might find evidence of that unilateral vestibular loss, like a deficient head impulse test towards the affected side. But prominent spontaneous nystagmus is usually absent because the loss is chronic and well compensated.
And diagnosis requires.
As we mentioned earlier, the definitive diagnosis requires that MRI of the internal auditory canals with gadolinium contrast to visualize the tumor. This is essential to rule out in any patient with unexplained unilateral hearing loss or objective unilateral vestibular hypofunction.
Okay, so that's unilateral slow loss. What happens if function is lost on both sides? Bilateral vestibular hypofunction.
Right. This means there's a significant loss of vestibular function affecting both inner ears or vestibular nerves.
And like the schwannoma, these patients typically don't have vertigo either.
Correct. Again, because the loss is usually symmetric or becomes symmetric over time, there is no conflicting signal asymmetry to cause the illusion of motion. Instead, their main symptoms are quite distinct.
What are they?
Severe loss of balance, especially in challenging conditions like walking in the dark, on uneven ground, or closing their eyes in the shower situations where they can't rely as much on vision or proprioception to stay upright. And the other hallmark symptom is oscillopsia during head movement.
That bouncing vision again.
Exactly. Because they lack the VOR bilaterally, their eyes don't stay stable when their head moves, making the world appear to jump or blur with every step or head turn.
What causes bilateral loss?
The source lists several possibilities. Sometimes it's idiopathic and progressive, meaning the cause isn't found. It can be part of neurodegenerative disorders. A major cause is iatrogenic, meaning caused by medical treatment, particularly ototoxicity from certain medications. Gentamicin is the classic example, but other drugs can do it too. It can also occur with bilateral schwannomas, often seen in neurofibromatosis type 2 or NF2, certain autoimmune conditions, infections affecting the meningers, or even some polyneuropathies.
How is it diagnosed on exam?
Key findings include that significantly diminished dynamic visual acuity we discussed. The head impulse test will often show absent function, meaning clear catch-up saccades when turning the head in both directions. And caloric testing typically shows severely reduced or absent responses bilaterally.
And the treatment, is it medication?
No, the primary treatment for bilateral vestibular hypofunction is intensive vestibular rehabilitation therapy. The goal is to teach the brain and body to maximize the use of remaining sensory inputs, vision and sensation, touch and joint position sensor, to substitute for the lost vestibular function.
And definitely avoid suppressants.
Absolutely crucial to avoid vestibular suppressant medications in these patients. They would only further impair the already limited vestibular input and significantly worsen their imbalance and oscillopsia. A neurologic evaluation is often recommended to look for underlying causes.
Okay, shifting now to central vestibular disorders. These are the ones originating in the brain itself.
Yes, meaning the lesion causing the vertigo or imbalance is located within the brainstem or the cerebellum. The potential causes here are serious.
Such as?
Stroke is a major one, either ischemic due to a blockage or hemorrhagic due to bleeding. Demyelination, as seen in multiple sclerosis. Tumors within the brainstem or cerebellum. Certain neurodegenerative diseases, or sometimes rare things like paraneoplastic cerebellar degeneration.
And the source emphasizes the urgency here.
Very strongly. Acute onset central vertigo is considered a medical emergency because of the high risk of stroke. Prompt evaluation is critical. Typically requires a brain MRI and a full neurologic evaluation, specifically looking for those accompanying central signs and symptoms we discussed earlier: double vision, weakness, numbness, speech difficulty, limitaxia, and those specific central patterns of nystagmus.
Right. Now, there's one more category of dizziness the source discusses, which sounds complex: psychosomatic and functional dizziness, often diagnosed now as PPPD.
Yes, persistent postural perceptual dizziness, or PPPD. This section really highlights the significant role that psychological factors can play, especially in chronic, persistent dizziness that doesn't seem fully explained by objective tests.
How does psychology play into dizziness?
Well, dizziness itself can be a physical, somatic symptom of underlying psychiatric conditions like depression, anxiety disorders, or panic disorder. Alternatively, someone might have an initial, real physical trigger for dizziness, like an episode of BPPV or vestibular neuritis, but then they develop significant anxiety about the dizziness, worrying about when the next spell will hit.
And that anxiety then feeds back and makes the dizziness worse or persist.
Exactly. The anxiety becomes a comorbidity that contributes significantly to the ongoing symptoms and disability, even after the initial physical problem might have resolved or compensated.
So what exactly is PPD? How is it defined?
PPPD is described as a chronic condition, meaning it lasts for 3 months or more. It involves a feeling of fluctuating dizziness, unsteadiness, or non-spinning vertigo that is present on most days. Critically, it's often present even when the person is sitting or lying still, but it gets distinctly worse in specific situations.
Which situations?
It's typically exacerbated by being upright, standing or walking, by active or passive self-motion, and by exposure to complex or moving visual stimuli, things like scrolling on a computer, being in a busy supermarket aisle, or watching an action movie.
So a real sensitivity to posture, motion, and visual environments?
Yes, a characteristic hypersensitivity. And importantly, vestibular function tests in people with PPPD are often normal. Or they might show evidence of a previous vestibular issue that is now well compensated physiologically. The ongoing subjective dizziness isn't adequately explained by any active primary vestibular pathology found on testing.
And anxiety is common with it.
Very common.
Yeah.
Anxiety is a frequent comorbidity in PPPD and significantly contributes to the patient's distress and functional limitations.
How is PPPD treated then?
The source outlines a multi-pronged approach. It often involves medications, particularly SSRIs, selective serotonin reuptake inhibitors, a class of antidepressants, which seem to help not just with associated anxiety, but often with the dizziness symptoms themselves. Cognitive behavioral psychotherapy, CBT, is also key, helping patients manage anxiety, change maladaptive thought patterns about their symptoms, and gradually re-engage in activities they've been avoiding. And specialized vestibular rehabilitation is also used, adapted to gradually desensitize patients to the visual and motion stimuli that provoke their symptoms.
And what about suppressants here?
Generally avoided, similar to other chronic vestibular conditions. The source notes that benzodiazepines might offer some temporary relief for acute anxiety flares, but SSRIs are really the preferred pharmacological treatment for the underlying PPPD condition itself.
Okay, so let's quickly recap the general treatment principles pulled together from the source, maybe referencing that table mentioned. Medications like antihistamines, like meclizine, benzodiazepines like diazepam, and scopolamine.
Primarily for short-term use only, to manage severe symptoms during an acute vertigo episode, like in vestibular neuritis or maybe an acute Ménière's attack, usually just for the first few days.
And the source repeatedly emphasizes why to avoid chronic use.
Yes, because they hinder central compensation and adaptation. They basically dampen down the very signals the brain needs to receive in order to learn how to cope with a vestibular deficit or recalibrate itself. Long-term use can lead to worse imbalance and prolonged recovery.
Exceptions being.
Benzodiazepines or SSRIs, when used specifically to treat associated anxiety disorders, or SSRIs as a primary treatment for PPPD, as we just discussed.
Got it. And the main non-medication therapies.
Physical therapy options are huge, specifically the repositioning maneuvers like EPLI, which are the primary treatment for PPPV, and then the broader category of vestibular rehabilitation therapy, VRT, for almost everything else involving vestibular loss or chronic dizziness.
Plus those other specific treatments mentioned.
Right, like diuretics and a low-sodium diet for Ménière's, anti-migrainous medications for vestibular migraine, and SSRIs again for PPPD or anxiety-driven dizziness.
Let's spend just another moment on vestibular rehabilitation therapy, VRT. What's the core idea behind it? How does it actually work?
The source material explains that the main goal of VRT is to promote central adaptation processes. Essentially, it's a form of physical therapy that uses specific exercises to help the brain relearn how to use the remaining sensory information from the eyes, the body, somatosensation, and any remaining vestibular function more effectively to compensate for a vestibular loss or dysfunction.
So it's retraining the brain?
Exactly, retraining the brain. It also helps patients habituate meaning, become less sensitive over time to the movements or situations that provoke their dizziness. And it can help manage those psychosomatic or anxiety-related aspects too.
And what do the exercises involve?
It's usually a structured program of graded exercises. They typically involve things designed to improve gaze stabilization during head movements, like keeping focus on a target while moving your head, and exercises to challenge and improve balance under different sensory conditions. The key is that it's progressive, starting easy, and gradually increasing the difficulty and complexity as the patient adapts.
Okay, wow. We have really gone deep, deep into the world of dizziness and vertigo, covering definitions, causes, the whole diagnostic pathway, specific conditions, and treatment strategies, all based on this incredibly detailed source material.
Absolutely, a comprehensive overview.
And then the material takes a significant turn to tackle another incredibly common but often just as challenging symptom: fatigue.
Right. And while people might sometimes use the words loosely or conflate them, fatigue is quite distinct from dizziness or weakness. The source defines it clearly as a subjective experience.
A feeling.
Yes, that feeling of weariness, sluggishness, low energy, or profound exhaustion. Clinically, it manifests as difficulty initiating or maintaining voluntary mental or physical activity.
When does it become clinically significant, not just everyday tiredness?
The source notes it becomes significant when its cause isn't clear, when it's persistent over time, or when the level of fatigue seems disproportionate to any identifiable activity, illness, or stressor the person is experiencing.
And just like with dizziness, it's crucial to distinguish fatigue from other related sensations.
Absolutely essential. The source explicitly lists several things fatigue is not. First, muscle weakness.
How is that different?
The source points out that most patients complaining of subjective fatigue do not have objective, measurable muscle weakness when formally tested by a clinician. It specifically distinguishes subjective fatigue from the fatigability of muscle power.
What's that?
That's where a muscle's actual force output measurably declines with repeated contraction. You see that in specific neuromuscular conditions like myasthenia gravis. That's an objective physical finding, whereas subjective fatigue is primarily a feeling or perception.
Okay, so not weakness. What else?
It's also distinct from somnolence, which is sleepiness or drowsiness related to problems with sleep-wake regulation. Someone might feel tired because they're sleepy, but it's physiologically different from fatigue. And it's distinct from dyspnea on exertion, shortness of breath with activity, although patients might sometimes use the word fatigue to describe feeling breathless or winded.
So, again, clarifying the language is step one.
Always. The clinical task when evaluating fatigue, as presented in the source, is similar to dizziness. Figure out the underlying cause if possible, build a good therapeutic alliance with the patient, avoid unnecessary, often low-yield testing, and try to find effective therapies.
Does the source give any sense of how common fatigue is?
It does give some interesting prevalence numbers. One U.S. survey found a lifetime prevalence of about 25%. In primary care clinics in Europe and the U.S., somewhere between 10–25% of patients report prolonged or chronic fatigue. A survey in India found 12% of women reporting chronic fatigue. But interestingly, it notes the actual prevalence of diagnosed chronic fatigue syndrome, or MECFS, is relatively low compared to how many people report feeling fatigued.
Okay, so what are the potential causes? Where does the source start with the differential diagnosis for fatigue?
The first major category listed is psychiatric disease. Fatigue is noted as being a very common somatic or physical manifestation of conditions like depression, anxiety disorders, and somatoform disorders.
A physical symptom of a mental health condition.
Exactly. And it provides a striking statistic. Over 75%, three-quarters, of patients who present to doctors with unexplained chronic fatigue are found to have current psychiatric symptoms upon evaluation. Yeah. And even if there is an underlying physical illness causing some fatigue, the source emphasizes that comorbid psychiatric disease having anxiety or depression alongside the physical illness is a major contributor to the severity and impact of the fatigue the patient experiences.
Okay, so psychiatric causes are really common. What's the next major category discussed in this part of the source?
The other major category discussed here is neurologic disease. Fatigue is also described as a frequent and often highly bothersome and disabling symptom in many different neurologic conditions.
Similar to psychiatric causes, is objective weakness common here?
Again, the source emphasizes that objective muscle weakness on examination is actually rare in patients presenting primarily with neurologic fatigue. If significant weakness is found, of course, that requires specific investigation to localize the neurological problem.
And it reiterates the distinction with muscle fatigability.
Yes, it makes the point, again, that true fatigability of muscle power, like you see in myasthenia gravis where the muscle demonstrably weakens with repeated effort, is a distinct phenomenon from the subjective feeling of fatigue, even when that fatigue has a neurologic origin.
Which specific neurologic diseases does the source mention in relation to fatigue?
It specifically highlights multiple sclerosis, MS. It notes that fatigue affects nearly 90% of people with MS, making it one of the most common and often most debilitating symptoms. It can persist even between clear relapses, and interestingly, the severity of fatigue in MS often doesn't correlate well with the amount of disease activity seen on brain MRI scans.
So it's a real symptom, even if the scans look stable?
Absolutely. It also mentions that fatigue is increasingly recognized as a significant and bothersome feature in many neurodegenerative diseases,
Yeah.
although it doesn't list specific ones in this sentence. And it adds that subacute cerebellar degeneration, a relatively rapid deterioration of the cerebellum, can also cause fatigue.
And is that where the text cuts off?
And unfortunately, yes. That's exactly where the provided text on fatigue abruptly ends, mid-sentence, right after mentioning subacute cerebellar degeneration.
Right. So based strictly on the source material you shared for this deep dive, we've managed to define fatigue, clarify how it's different from weakness, sleepiness, and breathlessness, noted its high prevalence, and started exploring the differential diagnosis, specifically focusing on those very significant contributions from psychiatric conditions and several neurologic diseases.
That's right. We covered everything provided in the source on fatigue.
Wow, okay. We really did go incredibly deep into this material today. We started by truly mastering the precise language of dizziness, nailing down those crucial distinctions between vertigo, lightheadedness, faintness, and imbalance.
Understanding those terms is fundamental.
Then we explored that systematic approach to diagnosis, those three key questions: dangerous, vestibular, peripheral or central, and we saw the immense power of a meticulous history and a focused physical exam.
Especially the eye movement analysis and those critical bedside tests like the head impulse and Dix-Hallpike, they tell you so much.
And we walked through that whole spectrum of specific conditions, didn't we? From acute vestibular neuritis and that elegant mechanical fix for BPPV,
Did that play maneuver?
to the complexities of vestibular migraine, Ménière's disease, the slow, subtle presentation of a schwannoma, the unique picture of bilateral vestibular loss, the urgency of ventral disorders, and that really complex interplay of mind and body in PPPD.
A huge range of possibilities under the umbrella of dizziness.
And then we shifted gears to begin dissecting fatigue, clearly defining it, distinguishing it from its common mimics like weakness and sleepiness, and identifying its strong links to both psychiatric conditions and common neurologic diseases like MS, all based precisely on the source material you provided.
Getting that level of detail, understanding the why behind the symptoms, the tests, the treatments, that really is what's needed to master this area, like the elite professionals who likely wrote this material.
Absolutely. So here's a thought to leave you with, building on everything we've unpacked from this source. Consider how the very subjective nature of symptoms like dizziness and fatigue really challenges clinicians. It requires them to cultivate not just sharp scientific knowledge, but also the sort of art of deeply listening and observing the patient.
It's not just about the tests.
Exactly. And how understanding that potential overlap and interaction between physical factors, neurological processes, and psychological well-being isn't just helpful. It seems absolutely essential for accurate diagnosis and truly comprehensive, effective care.
It really underscores that sometimes the most advanced diagnostic tool we have is simply paying careful, thoughtful attention to the person in front of us.
Couldn't agree more. Thank you for bringing us this incredibly rich material and allowing us to take this deep dive with you, aiming for that level of professional mastery.